Hi everyone, I'm the John Locke alumni Annie, and today I'll be breaking down the second prompt from psychology category for John Locke Writing Competition 2026. Most of you think to tackle this question of whether mental illness is overdiagnosed or better recognized from a basic, superficial level. We'll look at rising statistic of prevalence rate, compare them to 1950s, and conclude that people are just talking about it more. But as John Locke alumnus, I'm telling you, this is not what judges want. That approach will not get you shortlisted. The prompt presents an exclusive or what you call a binary choice, but the reality is a complex interaction of clinical measurement, socioeconomic drivers, and market logic. Today we're going to deconstruct the diagnostic paradox by looking at why the answer isn't just one or the other, but rather how the definition of the human condition is being mechanically re-engineered. So to analyze this, we must first define our scope. Mental illness is too broad, so to be precise, we must focus on the anxiety disorder or major depressive disorder, or something like this. These represent the highest volume of diagnosis and the leading causes of global disability. When we talk about overdiagnosis, we aren't just talking about too many people being diagnosed. We're talking about a measurement artifact. We must ask, what is the formal standard of diagnosis? In clinical psychology, we use the DSM-5, but as some of you might know, the ICD and the DSM-5 has evolved through many iterations, and the definition for mental illness also changed over time. So that diagnosis also requires a threshold. If we lower the threshold or the criteria for what constitutes a clinical distress, the increase in number isn't just recognition, it is a reclassification of human experience. We aren't finding more illness, we're shrinking the territory of what we call normal. So for example, many descriptions in DSM-5 for mental illness relates to some disability to work or being functional in sustaining oneself financially. So you may think about the socioeconomic implication of labeling someone who is unemployed or has disability as mentally disabled or disabled in general. And next, we'll talk about a technical reason why our data might be skewed by looking at the jingle-jangle fallacy in cognitive neuroscience and psychology. So to begin with, the jingle fallacy occurs when we use one label, like anxiety, to describe two completely different things. For example, the biological panic of a clinical disorder and the rational distress of living in a high inflation economy. Because they share the same name, we treat them with the same medical tools. This creates an illusion of overdiagnosis. The jangle fallacy, on the other hand, is the opposite, when we give two different names to the same underlying problem. This fragment cares and make it look like we're recognizing new condition, when we are actually just rebranding existing ones. These aren't just semantic errors, they are measurement artifacts. If our scales for measuring mental illness are semantically unstable, then our diagnostic rates are a reflection of our faulty tools, not necessarily the state of the population. And next, we must also follow the logic of the money. In the American market, mental health has become a high-volume, subscription-based business model. Venture capital and private equity firms have invested billions into digital health platforms. These platforms operate on throughput efficiency. Their goal is scale, conversion, and retention. In this model, a diagnosis is a functional necessity for a transaction. If a patient is not diagnosed, they cannot be billed for insurance, and they cannot be prescribed medication. This creates a mechanical pressure to diagnose. When psychological services enter the mass market, they become beholden to the marketplace values. We aren't just recognizing the illness, we are penetrating a market. The medical model is prioritized because it's easier to scale than deep psychosocial support, like talk therapy or community therapy. Now, let's apply some critical pressure. The overdiagnosis claim is a form of medical gatekeeping. Proponents of the better recognized view argue that the rising number represents a triumph of public health. For decades, women, minorities, and low-income individuals have their suffering dismissed as laziness or personality flaws. Modern diagnostic rates finally grant these marginalized population the access to the treatment gap, providing them with medical validation and resources they were historically denied. But the rebuttal comes. This argument confuses the access with accuracy. While expanding the care to marginalized is a moral imperative, medicalizing their social and economic suffering is not a win. By labeling the distress caused by poverty or systematic inequality as a brain chemistry imbalance, we shift the burden of change from the society to the individual. We're not recognizing a biological fact. We are pathologizing a rational response to environment. This is diagnostic colonization. It replaces human meaning with clinical measurement. We might be providing access, but we are providing access to a system that prioritizes optimizing the unit for productivity rather than addressing the root cause of the distress. So, is it overdiagnosed or better recognized? It is both, and it is neither. It's a cultural mutation. We have moved from a society that interprets suffering through philosophy and community to a society that interprets it through the lens of medicine and commerce. When you write your essay, don't just pick a side. Analyze the mechanism, such as the jingle-jangle fallacy, the market throughput, and the shift in cultural values. That is how you think bravely, like what a John Locke alumni should be. And that is how you get the attention of the John Locke Institute. Good luck, everyone.